Okay, so this is chapter 10, part 3. So supplemental oxygen. This is the first drug that you can give. It is a non-prescribed drug, which means that you follow your standing orders associated with the delivery. So we need to remember that if the patient is not taking in oxygen appropriately, it's our time to give it to them. And we don't withhold oxygen from any patient who we believe might benefit from it. And that's not just a physical benefit, that is also going to be possibly a psychological benefit. You need to become familiar with how you store your oxygen in your ambulance. You will have portable bottles, you will have the larger bottle that's going to sit in your truck, and the different sizes that are there. I know in the chapter there's information on how much each size cylinder holds, and you're going to want to review that, maybe not for my test, but for the National Registry. Understand that what we carry tends to be compressed gas. Liquid oxygen is becoming more common, but you see that more in at-home oxygen. Those who are on home O2. We actually used to have it at East Hanover, but it was kind of a pain in the butt to use and to refill. So what are some safety considerations? I think we all know the number one that they don't have here, and that's don't smoke around the oxygen, nor do you let your patients smoke when they're on oxygen. Make sure that you've got the correct pressure regulator attached and that it's attached firmly. So the delivery system and the pressure regulator is going to be different. There are some agencies that will use nitrous to help with pain management because, it kind of makes them feel loopy. And the regulator for that is going to be different than the regulator for oxygen. Be cautious because if you drop the regulator, if you drop your oxygen cylinder and it gets a hole in it or a crack, it will actually become a missile. I've talked to scuba divers who have seen scuba tanks go through brick walls when they weren't handled appropriately. So also make sure that when you're transporting your patient, if you're still using the smaller cylinder, that you have secured it. Remember that the pressure regulator's job is to reduce the pressure in the full cylinder to a truly therapeutic range, which is normally 40 to 70 psi. And then what we're going to do is we're going to use a flow meter to determine how fast that oxygen is going to be delivered through our delivery device. The flow meter is going to be attached to the regulator. So when you remove the regulator to change out your oxygen, you're removing the flow meter. And you've got to consider the fact that oxygen does have hazards. It is flammable, highly combustible, and especially in your COPD patients in longer transports, you're going to be looking at the potential that you actually kill the receptors in their brain that tell them they need to breathe. So, just a little on the combustion side, oxygen doesn't burn or explode, but it does speed up the process. You need oxygen to have fire. You take away oxygen, you take away fire. Those firefighters in the class are nodding their head going, well, duh, we knew that. So make sure that it is an adequately ventilated space. As I've said, don't let your patients smoke, and you shouldn't smoke in or near an ambulance because it is high levels of high concentration of oxygen in the back. We've talked about this, so I'll kind of just glance over it. Remember that we want to administer a minimum amount. If your patient's a COPD patient and they're experiencing difficulty breathing and they're on 2 liters at home, bump them up to 4. But you don't necessarily need to give your patient a significant amount of oxygen just to make them feel better. So on the screen, you'll see the 2 methods, apparently I can't count, you'll see the 3 methods that we can use to deliver oxygen to our patient. 2 of them are going to be patients who are conscious or semi-conscious, and one of them, for the most part, we consider using when our patient is fully unconscious, in respiratory failure, respiratory arrest, but there's actually some other times we'll use it. So the non-rebreather is going to be our preferred method in the pre-hospital setting. The non-rebreather is the one that goes over the nose and the mouth and has that reservoir bag where it's pulling some higher concentration of oxygen. When you see it used on TV, most of the time that bag is not inflated. You aren't on TV, so please, before you use it, inflate the bag. Like that says, make sure the reservoir bag is full. The way to do that is that you will go into the nose area of the mask and cover the two prongs after you've turned the oxygen on, and just fill the bag up. We flow a non-rebreather at 10 to 15 liters per minute. So when you're taking the state test and you've assessed your patient and they're having difficulty breathing, what you're going to say is that you're going to place your patient on 10 liters of oxygen via non-rebreather. NRB is another way. So 10 liters O2 via non-rebreather via NRB. Again, that non-rebreather is actually a high percentage of oxygen being delivered. The second option is your nasal cannula. This is that feel good. This is what most of your at-home oxygen people are on. We tend to only use a nasal cannula in real life when our patients can't tolerate a mask. It's just such a low level of oxygen flow that we don't really find any significant therapeutic value in our patients. But as I've said, if they are already on a nasal cannula and they're not having difficulty breathing, just keep the nasal cannula on them. You only get about 24 to 44% oxygen through the use of the nasal cannula. And what people tend to forget is that's only if the patient's not a mouth breather. So if they've got a nasal cannula up their nose, but they're breathing in and out of their mouth, it's really not doing a whole lot of good. The other problem with the nasal cannula is that it can dry the nasal passages out. And like we said, we have our nose to provide humidified, warmed air. When you dry the nasal passages out and the airway passages out, it can actually make breathing issues even worse. We do have partial rebreathing masks. The only difference here is there's no one-way valve. So on the non-rebreather, remember that one-way valve is not going to let you breathe in lower concentration of oxygen again. So when you breathe out carbon dioxide, it's just going to stay there out in the environment because of that valve. When you have a partial rebreather mask and it doesn't have that valve, there's always a chance that your patient's going to breathe in a lower saturated level of oxygen. This is called a Venturi mask. This allows you to impact the percentage of oxygen that's going to be delivered. We really don't see a lot of these. These are much more in the healthcare setting. The Venturi mask gets you 24 to 40% oxygen. Again, this is long-term transports when they're physiologically stable, not when they're having severe and significant difficulty breathing. Those patients we want on a non-rebreather because it's going to have a higher concentration of oxygen being provided to the patient. You may have a patient and you arrive and they've actually got a tracheostomy. Tracheostomy being a surgical hole in the throat to bypass the nose and the mouth for oxygen delivery. If they have a tracheostomy, then you may, especially in the non-emergency transport, you may have a tracheostomy. If not, you're going to have to take your non-rebreather and actually place it over the tracheostomy. You know, tracheostomy masks are designed to fit over the surgical opening in the throat. They're going to have a cord that allows it to stay tight around the throat. We don't tend to do humidified oxygen in the emergency transport setting, mostly because there's just not a need for it. We are in a short-term transport capability. It's taking us 20, 30, 45 minutes to get to the hospital. There's no need for humidification. Dry oxygen isn't considered harmful. It's those long-term trips. So if you ever get a job doing non-emergency transport for long periods of time, you may find that your provider actually has humidification on their trucks. Okay, so that's airway delivery, oxygen delivery and supplemental oxygen delivery to your patient. So now let's talk about assisted and artificial ventilations, recognizing that those are two different things. Remember, airway and breathing come before circulation, because if your patient can't breathe, it doesn't matter if they're moving blood round and round. We need to know that quality ventilation techniques are going to be significantly life-saving to many of our patients. We do assist ventilation. Our goal is to not wait until they're in respiratory failure. Respiratory distress is that massive sign that we should probably be doing more. If you wait until they are in respiratory failure, respiratory arrest, you have waited too long and failed your patient. So, what are the signs and symptoms of the inadequate ventilation? Remembering that ventilation is just the process of air going in and out. The altered mental status, the minute volume. So their tidal volume may be great, but they're not breathing at an appropriate number of times. Accessory muscle use and fatigue. So one of the ways we can assist is the bag valve mask, or BVM. I have actually bagged patients who were conscious. We don't think about that. When we think BVM in the training setting, you tend to think, oh, that's just when my patient's in respiratory arrest or when they're in cardiac arrest and they're unconscious. But if you've got a patient who's hyperventilating, you've got a patient who's conscious, but maybe isn't getting that right amount of oxygen, then you're going to have to help them. You're going to have to take the bag valve mask over their mouth, over their nose, just like you would an unconscious patient, and squeeze. So I'll tell my patients, all right, on the count of 3, breathe. 1, 2, 3, breathe. 1, 2, 3, breathe. You've got to consider the fact that they are going to fight it. And so that's why this says for the first couple of breaths, go with their respiratory rate. And then once you've done that, you need to get to a 12 to 20 per minute bagging rate. So you need to remember to count yourself. We found that when you're bagging a patient, it's really easy to lose count of what you're actually doing. So if your job is to bag, your job is to bag and nothing else. Okay? Patients who are in respiratory arrest, that means that their respirations have completely stopped. Those are the ones that you have got to get in there. Remember, 1 to 4 minutes before you start seeing brain death. But after that 4-minute mark, you are going to start seeing death of brain tissue. So you've got to be able to quickly assess your patient, recognize they're in respiratory arrest, and get that bag valve mask with supplemental oxygen. You know that we don't really like that we don't really like that mouth to mask technique because there is a hazard associated with that. That's an exposure issue. Really, your best technique is going to be your 2-person bag valve mask. 1 paying attention to the seal around the nose and the mouth, and 1 squeezing the bag with the appropriate tidal. As we've talked, normal ventilation requires the diaphragm contract and that negative pressure being generated in the chest cavity. When we use positive pressure ventilation, and you fire guys who have learned about this in fighting fires and in overhaul, positive pressure ventilation means we are forcing the air into the chest cavity. We are actually creating a different pressure environment in the chest cavity. So, you might get some resistance, and it works opposite of the way the body normally reacts. So, one of the things we have to consider is when we're doing positive pressure ventilation, like a bag valve mask, we can create interthoracic pressure issues, and which is then going to have the same issue associated with getting the heart going, moving the blood around. When we change the pressure in the chest cavity, the heart may not be able to contract and relax at the same level that it normally does. So you've got to be cognizant that your respiratory efforts in support of a respiratory arrest, so the way you bag the patient can actually have a negative impact on other body systems. You also have to know if you bag your patient too forcefully and the epiglottis doesn't get a chance to cover the esophagus, that you may see the patient's lunch right back at you. So this is why we say wear masks, goggles, gloves anytime you're working with the airway. Mouth to mouth, mouth to mask, Yeah, there's a barrier device occasionally, but if there's not a one-way valve, then there's the potential that that vomiting will come back in your mouth. And no one wants that, believe me. So what are the signs and symptoms that you need to be looking for of adequate ventilation? When I bag the patient, I should see equal rise and fall of the chest. If I don't see it, then I need to figure out why not. I want to see an appropriate rise of the chest for the squeeze of the bag. It should be of the appropriate depth based on the patient's age. I should feel and hear the air coming out after I've squeezed the bag. I can't put more air in if the carbon dioxide didn't come out. Picture of the bag valve mask. Notice all the different parts. I am not going to bag my patient without connecting it to supplemental oxygen. This will ensure that my patient is getting high levels of oxygen every time I squeeze that bag. Now, that doesn't mean to not bag until you can connect it to O2, but when we talk about the assessment of the airway emergency, one of the things to keep in mind is if your random skill is airway, then you will see that there is a time associated with getting oxygen attached to your patient and to the bag valve mask. If you have difficulty ventilating while your patient, you need to adjust the seal. You need to make sure that the head tilt, chin lift, the jaw thrust still is effective, that any airway adjunct that you've put in is still there. And you need to make sure your seal's good. Is there air escaping from a seal that isn't as good as you think it is? All of these could impact that tidal volume. If you do get a little over anxious when you're bagging your patient and cause gastric distension, you've got to remember that this is going to cause issues with getting oxygen into your patient. When the pressure in the stomach gets too big, it's going to push the diaphragm up, which is then going to cause your lungs not to expand as well as they should. So what do? You need to appropriately ventilate at the right rate, at the right depth. If the stomach is descending, again, recheck that head tilt, chin lift, and go back. Don't just stop. It might become harder, but you shouldn't stop. So what are some ways to passively ventilate? Well, expansion and contraction create a pump for air movement. So this is where hands-on CPR actually is helpful. So when you push up and down on the cardiac patient's chest doing hands-only CPR, you're actually changing the pressures in the chest cavity, which will cause that patient to take oxygen in every time you release it. We also have what are called the flow-restricted oxygen-powered ventilation devices, and because we like acronyms, I like to call it a FROP-VD. I'm probably the only one that does that, though. This allows a single rescuer to use both hands to maintain the seal, and it's a push button. So instead of having to use your whole body, all of your upper arms, all of your upper body to squeeze and seal and pay attention, your focus is using both hands to create the seal, and then pushing the button on the top of the device to deliver the oxygen. The problem here is it is significantly higher flow than normal. If you push it for too long, you're going to deliver too much. And because it is at a high pressure, you can actually cause damage to the lungs. Yep, see, and there we go. We don't routinely use it. It's hard to do the count when you're trying to count how to deliver the respiration, when to deliver the respiration, and how long to deliver the respiration. No doubt you're going to count inappropriately at some point. You might, especially in the non-emergency transport setting, transport a patient with a ventilator. So this is a manually triggered device. The automatic transport ventilator doesn't have quite the controls that your normal hospital grade ventilator does, but it does provide some hands-free ventilation assistance to your patient. Again, these are devices that once you're certified, that you would work with your agency if it's something that they expect you to utilize.